Healthcare workers are trained to save lives, but increasingly, they are struggling to save their own. Physicians, nurses, paramedics, chaplains, social workers, and trainees face suicide rates higher than the general population, driven not only by stress or depression, but by something deeper. What many healthcare workers experience is moral trauma. The psychological and existential injury that occurs when one's professional values are repeatedly violated by circumstances beyond one's control. Today, we'll explore what actually works in suicide prevention for healthcare workers through a faith informed lens that complements rather than competes with evidence based care. 1. Naming the real injury, moral trauma, not weakness. One of the most harmful misconceptions in healthcare culture is that suicide risk reflects burnout alone, individual fragility. Poor coping skills. In reality, many healthcare workers are injured by being forced to provide suboptimal care, witnessing preventable suffering, participating in morally distressing systems, feeling complicit in outcomes they oppose. Faith traditions offer a crucial corrective here. Moral injury is not moral failure. When suffering is framed as an understandable response to impossible demands, shame decreases and help seeking increases. What works? Language that validates ethical pain, teaching that anguish can be a sign of moral seriousness, not spiritual deficit. Explicit rejection of just be resilient narratives. Faith informed approaches restore dignity by separating moral worth from system outcomes. 2. Restoring moral identity in a system that erodes it. Healthcare systems often reduce clinicians to productivity metrics, risk exposure, compliance roles. Over time, this erodes moral identity, the sense of who I am as a healer. Faith traditions counter this erosion by grounding identity in vocation, not performance, faithfulness, not outcomes, presence, not perfection. For healthcare workers at suicide risk, what often helps most is not symptom reduction, but identity restoration. What works? Reclaiming healthcare as a calling, not merely a job, naming limits without equating them to failure, teaching that moral agency persists even under constraint. This reframing directly reduces despair linked to perceived moral collapse. 3. Community that understands the cost of care. Generic social support is helpful, but peer attuned community is protective. Healthcare workers are often isolated because they don't want to burden loved ones. They fear professional consequences. They believe no one outside medicine understands. Faith informed communities that work well for clinicians share 3 features: confidentiality, non fixing presence, shared moral language. This can take the form of small, closed support groups, interdisciplinary moral reflection circles, faith based clinician cohorts, chaplain facilitated safe spaces. What does not work? Spiritual platitudes, minimizing systemic harm, theologizing suffering without listening. What works? Being seen by people who understand the cost of caring. 4. Lament, not positivity, the missing practice. Healthcare culture often rewards stoicism and optimism. Faith traditions offer something radically different: lament. Lament allows clinicians to name loss without resolution, grieve without being unprofessional, speak anger, sorrow, and exhaustion honestly. This matters because suppressed grief fuels suicide risk. Practices that work include guided lament rituals, structured moral storytelling, memorial practices for patient loss, naming what should never have happened. Lament restores psychological integration where fragmentation has occurred. 5. Clergy and chaplains as moral witnesses, not fixers. For healthcare workers, faith leaders are most effective when they function as witnesses, not therapists, companions, not correctors, advocates, not spiritual supervisors, chaplains and clergy who are trained in suicide risk recognition, moral injury frameworks, referral pathways become powerful protective agents. What works is collaboration, not competition, with mental health professionals. Faith informed care should normalize therapy and medication, frame treatment as ethical self care, reject martyrdom culture, encourage rest as moral responsibility. 6. After the crisis, sustained presence saves lives. Healthcare workers often receive help during a crisis, but are abandoned afterward. Faith communities can fill this gap by maintaining contact after hospitalization or leave, offering quiet, non demanding support, providing practical help without interrogation, refusing to disappear once the emergency passes. Many clinicians who survive suicide attempts report that post crisis presence, not acute intervention, made the difference. Closing synthesis. Faith informed suicide prevention for healthcare workers works when it names moral trauma, honestly restores identity beyond performance, builds peer attuned community, creates space for lament, not forced positivity, partners with clinical care, stays present after the crisis. Healthcare workers do not need to be told to be stronger. They need spaces where their moral pain is honored, their limits are respected, and their lives are valued beyond their utility. Faith, when practiced wisely, can help heal what medicine alone cannot.